Well, good morning, Laurel. And again, thank you for taking the time to come in and to come into your office, your shared office, and speak with us about being an alumni of Mercyhurst University, being a nurse, and being a nurse practitioner. So, if you could first of all share with us a little bit about your educational journey and your clinical experiences and journey as well.
Absolutely. I am actually a Mercyhurst alumni times two. I have a bachelor's degree in graphic design and art, and I then switched careers later in life and went into nursing. So I went to Mercyhurst main campus out of high school, and then later as an adult, I went back to Mercyhurst Northeast while that campus was still open to get my RN. And from then, I went on to get my BSN and then my master's through Chamberlain University, which is online. Um, as far as my clinical experience goes, I worked as an aide in the hospital while I was in nursing school, which I highly recommend. And then I worked at I've only exclusively worked at St. Vincent here in town, and I worked on 8 North, which is a medical surgical oncology unit for many years, and that was invaluable. And then I transitioned to working in oncology, doing chemo infusions and working specifically in that specialty for a couple years, especially while I was in school to get my NP. And then after I got done with my NP license, I started working at urgent care, but very quickly realized that was not for me and decided to transition into geriatric care in the nursing homes in town.
Okay. And how long have you been at or working at nursing homes as an NP? Has it been a couple of years? Is it?
Yep. It's been about 3 years now.
Great. Great. So tell us a little bit about because it's very diverse, your undergraduate education, and how did all of your educational experiences really help you to be a nurse, perhaps in ways you didn't even realize at the time?
So the first part of your question there sort of broke up, so I didn't get the first part.
Sure. So you have a very diverse undergraduate education. And, going, from a traditional program here at Mercyhurst to the nursing program. And how did your undergraduate education prepare you to be a nurse, perhaps in ways that you didn't even expect that to happen?
Yeah, absolutely. Goodness. The liberal arts education as a whole, I think, gets a lot of flack, especially in recent times, because, it's a lot of, well, why do I need to take these courses? They're not related to what I need to do in my job. And in reality, especially when you're working with people and all kinds of people all day, every day, it's really important that you have a broader understanding and a lot of empathy for humanity. And I found that having an art degree and understanding history and understanding literature and culture and religion really does give you a step up in helping to take care of your patients in a more thorough manner. Because one of the things that I think really separates nurses from, let's say, PAs or even physicians is that, and I know this because I went to Mercyhurst, they teach you to take care of the patient as a whole person, and that includes their culture, their background, their religion, their food preferences, their family, their kids, their grandparents, their dog. I mean, everybody, right? Everybody's included. And, taking all of that into consideration really does allow you to give the most, just the most spectacular care to the patients. And I mean, it's evident when you see them and you talk to them and you take that time, it really does make a big difference in their lives.
That is a wonderful response. And I know I didn't ask you that question ahead of time. You weren't prepared. But if I could just cut out that snippet and just show it to each and every one of our students here, that would be wonderful. Because I can say
it
it.
really is true though. Yeah. You know, you're reading the
Yeah.
Iliad and the Odyssey and you're like, why in the world am I doing this right now? Like this is a giant waste of time. But then, you know, like, you know, it's not like you're pulling quotes from that book, you know, out when you're talking to patients, but just having an understanding of like the world is bigger than you and you're one person. And just being okay with that and accepting that is really part of it. It really is.
Beautiful. Thank you. Thank you for that. Definitely. What motivated you to continue your education as a nurse practitioner?
Well, there's two things. You want me to be really honest?
Absolutely. Be really
Okay.
honest.
So the two things that really motivated. So when decided to go back to nursing school, this is kind of like a little personal aside. I'll make it very short, which is I was having a really big transition in my life where I actually was working at Starbucks and I had been there for a really long time. And I was kind of at a point in my career there where I had to decide, like, am I going to stay here forever or am I going to be done and do something else? And my husband and I had a long talk and we kind of went back and forth about, you know, what are you going to do? Like, what are your thoughts? And my only goal at that time was I need good money and I need job security. And I know I'm good with people. So I guess maybe nursing, I don't know. And so, you know, that's really how it happened. And so I ended up getting into it. And, you know, lo and behold, I hate to be like a cliche, but it literally was my calling. I have never been in a job that I loved more. And so when we decided that, I looked at him and I said, listen, if I'm doing this, I'm doing this. I'm going to go for the big money. I'm going to go all the way and I'm not stopping. Like, I don't care. And so that is kind of what led me into this. But I will say, as a caveat, when I got into the hospital and I got my feet under me and I started feeling comfortable clinically and understanding patient care and understanding what my patients needed medically as well as, you know, emotionally, I didn't always agree or like how the physicians were handling the situation. Not that they were doing something wrong, but that I would have done it another way. It was very frustrating to me that I didn't have the control over the situation that I wanted to have. And that very much solidified for me that, like, this was the right path. This is where I needed to be. And yeah, sometimes making the decisions is, you know, it's like I tell my patients, it's big, bad, and scary. But at the same time, it gives you that control, and you can have those conversations with your patients where, you know, you're prepared to have those hard conversations, you know. And it just, I don't know, it's just such a freeing thing to be able to know that, you know, the good outcomes are not just because of me, but, you know, those decisions that you made cause those good outcomes to happen. And, you know, sometimes bad outcomes happen too, but again, it's all a learning experience and those are things you deal with along the way. So.
Mhm. Wonderful. Well, we hope all of our students are lifelong learners. So we do not have a nurse practitioner program, as you know, but we do have two masters, one in leadership and one in education, to either be a nurse educator like in a hospital or in an academic environment. And but we also encourage our students to go on and help them to find good programs for nurse practitioner, because I know that's or a nurse anesthetist. I know, you know, our students are inquisitive, they're bright, they're wonderful. So I'm glad to hear about your continuing education and going for it. And we hope they just continue to keep going. So that's beautiful. So thank you again for that. Um, and a question, because we've integrated mindfulness into this course as well. And and if you do, how do you use mindfulness or reflective practices in your professional or personal life?
Michelle's making a face over here too. Oh boy, do we reflect? Yeah. So I would have to say reflection is, I mean, goodness. I mean, it's daily. It's daily. It's every patient. I mean, you're constantly thinking about, oh, how do you even answer this question? the amount of reflection that you do is immense. So I would say I would break it down into personal reflection. You know, did I handle this situation the best way that I could? Did I speak with the family in a way that's going to be effective? Did I have a conversation with the patient on their level? How did I meet them where they are? Did you reflect about the exact decisions that you make. Did I medically make the appropriate choice for the patient? Did I make sure to look at everything? Did I look at their labs? Did I look at their results? Have I looked at the past notes? Have I talked to the staff? Have I done all those things? You're medically reflecting on the patient. And then you get home at the end of the day, you sit down on the couch and you think, oh my God, okay, did I forget anything? Did I do everything? Did I call everyone? Did I make sure I wrote all my notes? Then you're thinking about it again and again and again. And I would say that I do a lot less of that now that I feel more established in my career and where I am. But even as a nurse, speaking like at the RN level, when I worked in the hospital and you have 6 patients and you're running around like a chicken with your head cut off, and these people are all critical and they all need a million things, and you're the one who's in charge, like, you just get done at the end of the day and you're just so mentally exhausted that if you don't take the time to reflect on everything that you did during the day, it will swallow you. It will swallow you whole. I know nurses who, goodness, they really struggle with burnout and with bad coping mechanisms. And I think a lot of that is, that's complex, obviously, but professionally speaking, a lot of that is they don't take the time to think about, what did I do today? What did I do well? What can I do better tomorrow? What can I bring to my 12-hour shift tomorrow that, I didn't do today? How can I prepare, even if it's something as simple as, can I meal prep my food so that I know I'm going to eat tomorrow? Like she's saying yes to. It's like those little things that, it doesn't have to be a reflection journal. I don't know what you guys are doing, as far as class is concerned, but it doesn't have to be a journal. It can literally just be you're sitting on the couch, like head back, just thinking like, okay, what was my really big struggle today and how can I make that better tomorrow and not make my struggle tomorrow, and sometimes that's out of your control and you end up going in and you have 8 patients and sorry, but sometimes it is in your control and you can control your day and you can control your situation a little bit better. So I know that's what I would say about that.
Well, good. I know that that's part of the reason that we've integrated mindfulness practices and reflection into different courses. And because, yeah, the burnout rates are high. So we need to help prepare our nursing students to be effective nurses. And that includes how to deal, how to cope with the situations. And you're sharing, even preparing our meals ahead of time so that we eat that next 12-hour day, So
you're like, oh, I didn't prepare accordingly and now I'm not eating. Yeah. So
yeah. So excellent. And so other content that we have is like, we're going to be talking about advanced directives. What have you learned about the importance of advanced directives? And I'm putting in the big category. So yes, I know they're going to look at post, they're going to look at,
I'm not sure there is anything on this planet that is more important than having your advanced directives and understanding what they are, and also ensuring that your POA, the person who's making your decisions for you legally, if you cannot, is going to follow those and follow what you want. That, oh gosh, we don't have enough time. We don't have enough time to talk about this. I'm so passionate about this. It's so
what
crazy.
you just said means you have to have a discussion with the person who could be making those medical decisions, right?
Yeah. And yeah. So I think, yes, the answer is yes. The two most important things, I think, to get the conversation started actually start with you as the nurse. Understanding that most of the time, I'm not going to say all the time, but I would say well over 80% of the time, if you have an adult patient who has chronic illnesses, they're not afraid to talk about it. You are. I have had so many frank conversations with people about their status. And I think the most surprising thing that has come of this is how many people really are okay with just talking about it, and how many people want to talk about it, but they don't understand what it means. You'll get people who you'll say, oh, here's the post form, right? You're going to go over that in class, correct? You don't need me to go over it. Okay. Zach could grab one, no problem. So, you get your post form, which is just, it's not a legally binding document, but it's like a guideline, right? So you get it and you're talking to the patient. You say, okay, do you want CPR? And you're looking at your paper. Do you want CPR? Well, yeah, of course I want CPR. Okay, cool. Well, do you know what CPR is? And they say, oh yeah, it's when CPR, right? It's when you save my life if my heart stops. Yeah, that's right. But they don't understand what CPR is and what CPR does and how it works and how it saves your life, correct? So I typically have a conversation that goes something like this. Absolutely, we will absolutely do CPR for you if you want. Do you understand what CPR is and kind of what it does? And they'll say, well, yeah, it's like when you pound on my chest. Yeah, that's exactly what we do. We definitely pound on your chest. Sometimes, we break your ribs and it's not fun. And sometimes we could even puncture along. And CPR success rate it's pretty good when you're young and you're healthy and you don't have a lot of chronic illnesses. But when you're sick chronically, it can make things worse sometimes. And I just make sure that people understand that can we bring you back to life? Yeah, maybe we can. But what's your quality of life going to be after we do that? Maybe not so great. And then I explain to them, maybe we don't do CPR and that's okay, right? There's other things we can do that are on this pulse too. If let's say your heart doesn't stop, but there's some other serious things that are going on, we can give you these IV fluids, we can give you these IV antibiotics. That's pretty easy stuff. Most people say yes to that. And then we get down to the part where it's talking about nutrition, right? Do you want us to surgically insert a peg tube into you and you never eat again? You're never allowed to have anything by mouth. People don't always understand what that means to never put food into your mouth again, right? They think just nutrition, but I'm thinking, what about Thanksgiving dinner with your family? What about your favorite coffee, from Starbucks? Like you can't ever have those things again if you want us to do these things. They don't understand the full scope, right? So it's really about sitting down with them and helping them to truly understand. And I'm not sure where I got this phrase, but meeting somebody where they're at is like the most important thing, right? Not everyone has a college education, let alone a high school education. They don't understand the science of the human body. They don't understand how these things work. And, helping them to understand and meeting them at where, like I said, where they're at, their education level is, gosh, it's one of the most important things that you can understand as a nurse and maybe one day as a provider, depending on what they're all doing, and just helping them to understand the scope of their decisions. Cause I'm behind you. If you want CPR, you want me to pound on your chest, want me to do everything for you. Yes, ma'am. I will absolutely do whatever you ask me to do, as long as you understand. But that's the hard part, and then getting the POA to do the things that the patient wants when they don't necessarily agree with them, when it's their mother or their father or their brother or their sister, and they just want them to live. When the patient doesn't necessarily want those things, I mean, that's a whole other conversation. That's a whole other nuance. And these are things that come like with time and experience, right? But just being brave enough to have the conversation with the patient in the first place and helping them to understand and meeting them where they're at, I think is something a nurse absolutely can do. And it's a skill that I would recommend you get good at, because you will have that conversation with every single patient, every single hospital stay when they come in, because it is one of the first questions that you ask somebody, because we have to know what they want us to do. So that was very long. I could go on forever.
That was excellent. That was excellent. And it's
very
hearing these things, I can go over all this content and we can talk about it and discuss it, but actually hearing
it's very real.
your
It's very real.
experience. Yeah, and the importance. And along a similar line, when you have families dealing with dementia or serious, illnesses, what
Yeah.
are some, recommendations that you have for dealing with families that are dealing with a patient who has dementia of some sort? And we go
We
over
didn't
the
do
different types of
that.
dementia too,
Yeah.
because it can be
So
difficult. Yeah.
the is really tricky. Um, it's really tricky because every stage of it, you have to approach it in a different way, right? So when someone has mild dementia, mom and dad are just starting to be forgetful, and mom left the stove on, but she's fine at home otherwise, well, we keep an eye on her, and those kinds of things. That's a very tricky situation. Again, just having very honest and frank and direct conversations. I mean, without being a jerk, right? You're still being polite and professional, but just not just use direct language. That's the best thing that I've found is, what? Yeah, like I'm sure mom wants to be at home. We don't want her to be in a nursing home if she doesn't have to be here. Absolutely not. However, we have to remember that safety is the biggest concern. You know, can we trust that mom's not going to forget about the stove? Can we trust that she's not going to just wander outside and forget where she is? Like where are we in that situation? And in those instances, at least in my practice and with, Dr. Hancock's and the other nurse practitioners on my team, we rely heavily on a service called neuropsychology, which if you're in the hospital, those are like the people that get called when you're trying to find out if somebody's competent to make their decision, right? And so we have those people available to us as well in the nursing homes. And so what we'll do is we'll call up the neuropsych group and we say, hey, we have this patient. We're not like totally sure if they're going to be safe at home. Can you please come do a full eval? So we can do like oh my gosh, it's totally blanking on me. We can do all the different screening tools here, ourselves, but typically what we'll do is we have them come because they're kind of like, not that our word isn't important, but they are the word on it, right? So they'll come in, they'll do a full assessment with the patient. They do all the different screening tools. They have like a 45-minute block of time that they just sit and talk with the patient. And that gives us a much better understanding of kind of where they're at and their severity of their dementia. Now, if somebody's more like it's very clear that they obviously cannot make their own decisions, more to the moderate end of things or severe, the conversations that we have with families, at that point, the family knows, right? Like it's not a secret. The patient's mostly living here at the SNF long term, which is the skilled nursing facility. So I didn't learn SNF till I went to the hospital. SNF, SNF, skilled nursing facility. And so, those kinds of people, the conversations are a lot easier because they just understand it's been part of their life for a while now. They know mom and dad has dementia. It's not a secret. The conversation gets a little bit trickier when they get into the severe stage because that's kind of when we start de-escalating care and we'll say, well, does mom really need to be on these medicines? Can we take these medicines away? We start talking more, not that we don't do palliative in the other stages, but it becomes much more of a clinical focus when they get into that moderate to like end stage moderate to severe sort of situation. In that case, we would again like call the family and say, hey, we saw mom today. She's okay, but she's having a little bit of trouble with eating. She's, her mentation's a little bit, she didn't remember me today. I had to reintroduce myself today. All these signs clinically that show us that, they're kind of taking a turn for the worse. Not necessarily like hospice, they're not going to die, but we're just kind of getting to that point. So I would say, I don't know that mom really needs to be on that statin anymore. She's 87. She has less than 10 years life expectancy left. She might have we can get rid of that. We don't need that. Pill burden is like a real thing. So we get rid of that medicine, and mom's had a couple of falls in the last couple of months and she's on Eliquis and, a blood thinner. I don't really think that she's really appropriate. Risk versus benefit. The risk of her falling and hitting her head and having a bleed is really high. So you know what? I think it's worth just getting rid of that medicine. And, she's on this Namenda and, her dementia is so severe now, the medicine's not really doing anything for her. Why don't we get rid of that too? And so we just kind of go down line by line in their med list and we start de-escalating that care. And that conversation can be a little bit hit or miss. It really depends on how much acceptance the family has of like what's going on and how bad it is. But again, that kind of goes back to me and my responsibility and what kind of job I'm doing, having that open communication with the family and making sure that they're on the same page all the time and what's going on. So conversations just vary based on the patient's condition and how much acceptance the family has of what's going on with their family member.
Mhm.
So,
But the importance of open communication and having that
Yeah.
communication and listening too to what the family's ideas and
yeah,
expectations are,
yeah,
right? I
there's a
mean,
lot, yeah, exactly. There's a lot of education. And so earlier, not to like circle back, but we talked about the liberal arts education and understanding the patient as a whole person, right? And so, you know, I don't know how much experience your students have with like physically seeing someone who has end stage dementia, who can't even string a sentence together. They don't remember who you are. They can't remember how to eat food. Like, I mean, these people, I don't want to say they can't do anything for themselves, but they pretty much cannot do anything for themselves. So to have a conversation with them is like, respectfully, it's not happening, right? Like it's a lot of, oh yes, yes, honey, sure, you know, and oh, of course, because like they're just mumbo jumbo. There's a lot of gibberish going on. It's not anything that makes sense. So when you go have these conversations with the family, you really do get a sense of taking care of the patient as a whole, right? Because the family is going to talk to you about, well, mom didn't want that. You know, mom's Catholic, you know, she would want this, this, and this. And, you know, she grew up Italian Catholic, so she only likes these kinds of foods. And maybe she's not eating because she's not getting, I don't know, her spaghetti or whatever it is, you know, and, you know, she doesn't like needles. So I don't know that we need to do labs anymore. Or, you know, there's a lot of things that you learn about the patient by talking to their family, especially like in my situation. I don't always get new admissions from the hospital, right? Like I walk into a facility and there's people who have lived here for 10 years who I'm just meeting, and now I have to establish trust. And yeah, so I know I'm probably gonna say it 1,000 more times, but meeting them where they are, right? Like understanding they don't know you, you don't know them. You have to build this relationship. It's takes time and it takes trust, right? And so sometimes I might not agree with how they want to handle something, and vice versa. And it's a lot of give and take, you know, like, listen, I'm willing to not do labs on mom anymore, but that means we have to DC her Coumadin because like I have to monitor her Coumadin. There's just no way around it, right? And they'll say, okay, you know, and there's a lot of education around that. So it's a lot of talking.
yeah. Yeah. Um, I'm just trying to think. I know I need to respect your time, Laurel. And how about, is there anything else you wish nursing students or maybe even practicing nurses understood earlier about caring for people living with chronic illness?
Oh my goodness. We don't have enough time. Oh, okay. Gosh, if I had to pick one thing, it would be understanding the difference between palliative care and hospice.
Mm, go for it. I like it.
Yeah, I think that would be my hugest thing. So palliative care and hospice are like cousins, right? They like hang out a lot, they're best friends, but they go their separate ways. So hospice is strictly end of life care. Now, someone can be on hospice for a while. Like I have a lady at Brevalier who's been on hospice for, oh my gosh, I think she's coming up on like 2 years, but she's like perfect and adorable. And she's like 102 and, you know, she qualifies. So it's fine. But really like they're essentially treating her palliatively, but she's qualified for hospice for a while. So hospice is end of life care, right? So like the goal, this is exactly how I explain it to my patients and their families. The difference between palliative and hospice is palliative is your goal is to stay alive as comfortably as possible. And hospice is your goal is to die as comfortably as possible. Hospice equals palliative equals life. Those are the two. That's because people get them confused so much. And I know that's like kind of frank, but like I said, you need to be direct with people because I don't want somebody to be like, well, I'm on palliative and that means I'm going to die. No. Palliative is anyone who has a chronic disease who's not going to get better and it's only going to get worse. The goal is, okay, you have congestive heart failure. It's never going away. We're never curing it. It's only going to get worse. Our goal is to make sure that we give you the fullest life possible while treating your disease, right? So let's take congestive heart failure as an example. If the person has CHF and they have one exacerbation, maybe two exacerbations a year, meaning their legs fill up with fluid, they have trouble breathing, they're having some chest pain, they're having trouble getting around, right? All these normal symptoms. 2 hospitalizations a year is like a huge problem because, okay, so they're in the hospital for a week, right? They're getting IV diuresis, Lasix, whatever. They're getting the fluid off. I don't know where these students are in their learning, so I'm trying not to be like too medical. They are getting maybe some fluids just to make sure that they don't get a kidney injury on top because they're getting Lasix, right? Their appetite's down. They're weak because they're in bed. All these things that keep happening, right? They're super complex patient. So when they are done in the hospital, they don't go home. They come to me. So now they're in the hospital for a week. They're at the nursing home for, let's just say it's like a good situation, right? So they're in the nursing home for 2 weeks. So that's 3 weeks for one hospitalization. Now they're there twice. So that's 6 weeks out of their whole year, right? And so that's a lot. That's a lot of time, a lot of money, a lot of resources, a lot of stress. It's terrible. So palliatively, we would be looking at that patient going, okay, how do we keep them out of the hospital as much as possible? Like, it's not totally avoidable, but even if we can get it down to 1 hospitalization a year, that's going to be a good situation. So we're going to take a look at their meds. We're going to say, okay, maybe what we're going to do is we're going to make sure this patient gets follow-ups with their PCP once every 2 months. They're going to follow up with the CHF clinic. We're going to make sure they're following up with them once every, 3 to 4 months, right? They're going to get their weights done weekly. They're going to send those into their PCP. We're going to make sure that they're getting all of their preventative vaccines, all of their preventative exams. This person had a history of smoking for 20 years. They're going to get their chest CT, right? All those things that we do to manage the patient so that they can have a high quality of life. So they can go out and go to the beach. They can go out and go to the zoo and hang out with their grandkids. They can live their life as much as possible, right? Now, when that patient gets to the point where they're getting hospitalized 4 or 5 times a year, they're on 6 liters of oxygen at home, Lasix isn't working, the Bumex isn't working, their kidneys are now failing because of all the diuretics we've given them over the years, right? But we've gotten 4 or 5 extra years out of their life of good quality life, right? So that's the key, good quality life as much as possible. At that point, I would look at the patient and I'd say, hey, we're kind of on the cusp here. That's when I have that conversation that I have with the dementia patient family, right? Where I'm de-escalating care. I'm saying to them, hey, we're not quite to hospice yet, but you're on the tail end of palliative here. Like, we need to start really discussing, like, what's your pulse if we haven't done that? What is your advanced directives if we haven't done that? Who's in charge if something happens to you if we haven't done that? I want to make sure all that stuff's in line. At that point, they probably would have it. But if they didn't, we would definitely be addressing. And then I would let them know, hey, we're not at hospice yet, but this is what hospice means. This is what we would do when we get to that point. This is another thing I say to my patients all the time is everybody plans their birth, right? Everyone's like, oh, I'm having a baby. The baby's going to come out and we're going to have a water bath and there's going to be rainbows and unicorns and it's going to be glitter and happiness and, all this stuff. Right? Everybody does that. Everybody. They have a birth plan, they have a binder, right? We have 2 things in common, every single living creature on this planet. It is we are all going to be born and we are all going to die. And nobody wants to talk about the second thing, but it's going to happen to every single living thing on this planet. And it blows my mind that no one has a death plan. Blows my mind. And I tell that to people and I say, listen, I'm not trying to be morbid, but don't you want to have a little bit of control over the way you go out? Whatever that means to you. Do you want to suffer? Do you want to be having trouble breathing? Do you want to be coughing up disgusting phlegm and like being gross? Like, what do you want? Do you want me to make you comfortable? Like, how do you want to do that? And so we have that conversation, that tough, frank, meet me where you are conversation. And we come up with a plan and we say, hey, when you're ready, when it happens, this is blah, blah, blah. We're going to do this, and we're going to be at home because I don't want to be at a nursing home. I don't want to be at a hospital. Some people want that. So we come up with a plan. So that's really the big difference, right? Palliative is life and quality of life, and hospice is death with the goal of a good death. And that is what I'll say.
Excellent. Excellent, Laurel.
So I don't know. I'm
Laurel,
a weird person.
You have to also be in nursing education too. I mean, you have to be with our students, and I'm sure they're all going to agree. I'm going to hear that from them for sure.
Love that.
But thank you for your time, and I'm going to stop the recording. And then if you just stay on for a minute more, just wanted to again say my thanks.
Okay.